Thank you so much for the opportunity to talk again. I may speak with a little bit of pressured speech since we leave a little bit of time for discussion at the end of all of this. My talk title is a little bit aspirational, and I'm afraid that my slides and the data may not quite meet the high aspirations of the title itself. But the purpose of it is really to indicate kind of how I think about some of this from a clinical perspective, how I think many of the more experienced physicians and scientists in the room also think about this, which is really driven by patient care and how do we get patients to survive and really get through just profound illness. I think this is one of the really major motivating challenges that we have in critical care now and in care of the critically ill heart patient. And just to show some of the motivation for the current studies that I'm going to present, I'm just going to show in detail a clinical case along the way. So this is a patient I cared for several years ago at my prior institution, an unfortunate 25-year-old gentleman who experienced a cardiac arrest in the setting of cocaine use. After a very brief arrest period that was witnessed, high-quality CPR, the patient had post-arrest hemodynamic instability. We were consulted, decided to cannulate the patient right there in the ED and place the patient on extracorporeal circulatory support via VA ECMO. Post-cannulation, we did a formal echocardiogram. At that time, had a normal LV cavity, minimal ejection, most of which was through mitral regurgitation and just diffuse hypokinesis. Over the course of the day, we just had minimal pulsatility. Despite multiple opportunities or multiple efforts to optimize volume status, titrate inotropic support, a variety of different maneuvers, and over by the end of the day said, you know what, it's now time, we have to move forward on some kind of venting strategy, some way to maintain forward flow, because we just don't have pulsatility. Before going down to the cath lab for a planned MPhil CP placement, did another echocardiogram and demonstrated that we were too late, that just 12 hours into this, despite having super therapeutic PTTs across the board for the day, we had a large thrombus that had already formed in the LV. The reason I mentioned this case was at the time that this case occurred, our hospital was debating what's the appropriate venting strategy, do we need to vent? The literature at that time was really underdeveloped. There were postulated approaches to this as other groups were putting out just how they would manage the situation. Some of them said, you know what, instead of doing it prospectively, maybe we can retrospectively just follow the patients and consider a venting strategy expectantly, look for signs and symptoms of LV overload, interstitial edema, LV dilation. And the reason I mention this particular case is we see that the X-ray before ECMO, the patient's interstitial edema actually improved, and we see that the patient still had a catastrophic outcome without signs of LV dilation as well, just demonstrating some of the incredible challenges that we have. And Jerry, I just realized I don't know how to play the video here from up here. I don't know if anybody back in the room, this is a CFD analysis of ECMO flow at varying flow rates, just demonstrating how high up into the arch that we get with varying flow, depending on the fraction of cardiac output. So, things that we've learned from Dan is just the impact of ECMO on the failing LV, and just how increasing afterload on the LV can have a variety of effects, and that we would anticipate increased metabolic stress, potentially worsening LV function. In thinking through this case, one of the things I try to piece together just how this patient may have still developed an LV thrombus despite having no pulsatility on his PA line. I think of the bronchial circulation and how that's systemic circulation that still drains into the post-pulmonary capillary pulmonary veins to continue LV drainage and blood flow into the LV despite no forward flow through the cardiopulmonary circulation. So this really becomes just a major challenge of how do we maintain the setting of extracorporeal support, a heart state that'll promote recovery and really limit some of the deleterious effects of being on ECMO. Two major percutaneous options that we debated at that time and have continued to be debated in the literature are placement of a percutaneous VAD, an impelled device across the aortic valve, or a balloon pump, which is, again, our historical and classic unloading device in normal physiologic states. How these devices operate in the setting of retrograde perfusion from ECMO is not well understood. In the intervening years, there's been an accumulation of data, but that data is largely a single center experience. Again, some wonderful studies that have come out. I think I didn't see Benedict here, but I remember waving his paper around our hospital trying to demonstrate increased survival of patients who've been placed on VA ECMO with pVAD presented here several years ago, as well as retrospective studies that have really failed to find a benefit of one device over another. But the underlying message of a lot of these studies is, my gosh, are our patients doing poorly? The overall mortality of patients put on VA ECMO is something in the order of 60% across the board. So we just have an enormous amount of room to understand how to do this a bit better. In an effort to try to advance this, the joint collaboration between MIT and Abiomed is this wonderful dynamic collaboration I've just been delighted to be a part of for the last several years. Put together a study of 6 animals where we randomized the animals to either pVAD support or balloon pump after undergoing VA ECMO. But at first, we put the animals through induced acute cardiogenic shock. And the model that we use really owns a debt of gratitude and an intellectual foundation from Jacob Moeller's work, our collaborator and again, ACURE colleague here. And how we generate acute cardiogenic shock in these animals, again, a technique very, very similar to what Professor Moeller does, is microbead embolization of the left coronary artery, and you can practically just dial in the level of acute cardiogenic shock that you get with these animals. And by doing these serial embolizations, we very rarely get fatal arrhythmias, and we've now done, I think, 70 to 80 pigs over the course of several years and have become pretty familiar with how these animals progress. These are incredibly intensive experiments, as my Abiomed colleagues in the room who've been so vital to performing these can attest, doing biventricular PV loops, Millar catheters for pressure sensors throughout the animal, in addition to multiple support modalities simultaneously. Now, this particular audience is incredibly astute at PV loops, and so I won't belabor the point. Instead, just to demonstrate that what you see on the right side of the screen is our animal data, and we see the baseline loop in green, and then we see the shock loop there in black, and we see that we do indeed get a shock state, decrease in contractility, an increase in LVEDP, and then you also see an ECMO flow rate. This is a middling flow rate, and I can discuss some of this data later. But see variability in terms of how the animals respond to actually going on ECMO. This animal experienced an increase in its volume while its LVEDP was largely stable. Now, in terms of thinking through what particular support modality to do then we place the animals on one of 2 venting strategies, as I mentioned, either balloon pump or pVAD. And so the balloon pump data you see at the top and a representative PV loop. From our ECMO-only state at 50 mLs per kilogram per minute flow, we have the balloon done at 1:1, and we see in this particular animal actually an increase in the left ventricular volume, and not really much change, maybe a modest change in LVEDP. And then to the right, you see the hemodynamic changes. As you'd expect, see the inflation-deflation cycles of the balloon pump. From a very practical standpoint, in managing these patients and being concerned about them when I'm perhaps home and calling into the bedside, did my patient lose pulsatility as soon as you have a balloon pump in place? For the bedside practitioner who's not used to interpreting these in the setting of ECMO, this becomes a very challenging question. You may not have aortic valve opening, but you do have the appearance of pulsatility on the A-line. In contrast, we have the pVAD being placed, and now we see a reduction in stroke work. We see a lowering of LVEDP. And as you'd expect on the hemodynamic side, we see continuous flow throughout the cardiac cycle. So an increase in pressure in the diastole as well as a decrease in pressure during systole. We then, with our meager numbers, or a relatively small number of animals each side, did some statistics to demonstrate just what kind of effect we were seeing. And what we see here at 50 mLs per kilogram per minute flow, which, thinking through a 70 kilogram person or so, which is roughly the size of these pigs, that's a good 3.5 liters of flow, kind of a middling dose, if you will, of VA ECMO. We see that on the far right, we have the balloon pump, and then we see various P levels for the MPhil EP across the board, and this is a % reduction from VA ECMO alone. And so placing the pVAD gives us a significant reduction in the LVEDP versus being on VA ECMO. And you see that this, again, is very much dependent on the actual titration of the pVAD support. In comparison, the balloon pump actually gives us a very modest benefit to perhaps no benefit at all. As we extend this we look at different flow rates of ECMO, and we see that this benefit is preserved across the different flow rates, and perhaps becomes even a touch more pronounced as we increase the ECMO flow rate to increase the afterload that the animal in the failing LV is seeing. One of the other pieces of this is that this is a titration-dependent effect. So you have to actually titrate the impella. You can't just check the box and say, hey, I put the device in, problem solved. How we actually change the LVEDP is dependent on co-titration of these two devices simultaneously. We then look forward to looking at some of the other metrics in addition to LVEDP, calculated stroke work, and see a reduction in stroke work once the animals were put on pVAD versus a very modest increase in stroke work for the animals with a balloon pump. We also see the load-dependent contractility is markedly decreased. So really all these drivers that we've learned so much from Dan about of driving myocardial oxygen consumption, all these things are decreased in the setting of extracirculatory support with a concomitant pVAD placement versus the Impella, which really offers modest to no support at all. We then looked at that other thing we're trying to do, why these patients end up on extracirculatory support to begin with, circulatory failure. And so we're trying to restore circulation. How do these two devices work together to affect circulation and overall perfusion? And so we did a measurement of coronary perfusion, looking at the systemic blood pressure minus LV blood pressure, and we see that coronary perfusion, the driving gradient, is improved with a pVAD versus a balloon pump. Systemic perfusion, maybe a trend towards improvement in the pVAD and ECMO. And then we even measured, to the extent you can make analogies, and I'll ignore all the jokes about the pig's brain to the human brain and comparable sizes and how much that relates, but we also measured carotid artery blood flow and showed that with the presence of the pVAD, we even get a touch better carotid blood flow as well. So how does this motivate our practice? And so I wanted to wrap up by sharing another case, one of these really complex cases, which I think demonstrates the challenge of how we clinically care for these patients. Had a patient also several years ago, post-surgical patient who had a balloon pump placed pre-op in the setting of multivessel disease diagnosed in the cath lab. Came out of the OR and unfortunately had a VT arrest and immediately had an ECMO cannulation done at the bedside. The patient had the balloon pump and ECMO simultaneously, decided for simplicity of management and questioned whether the balloon pump offered any benefit. The balloon pump was then removed on post-op day 2. Tried to wean the patient off ECMO in the OR, failed, and said, you know what, let's put the balloon pump back in. Patient got another balloon pump. Another 7 days go by, repeat failed attempt to wean ECMO. Patient's hemodynamics didn't support it. So then we talked to the family and said, you know what, I don't think this patient's going to survive. I'm so sorry. This all happened, and again, we're always the heroes in our own stories, right? I then came on service and I said, you know what, humor me, let me just try something. Took the balloon pump out, put an Impella CP in, and then, oh my gosh, the patient started to get better. 3 days later, took the patient back down to the OR, successfully weaned off ECMO. 3 days after that, weaned off Impella CP. 2 weeks after that, eventually out to rehab and then on to home. When I'd last checked in on the patient before I'd made my institutional change about 1.5 years ago, the patient was still alive a couple years, had not been re-hospitalized in the intervening time. And so this is a patient who had this really complex course who, again, just demonstrating the complexity of managing these patients. I suspect Naveen Kapoor is going to be able to tell me at a chemical level what happened to this patient's heart, but I was very much motivated by this case saying, my gosh, the complexity of managing all these devices. We have to understand what happened to these patients and try to figure out a better way to support them. Just as I'll move through us in the interest of time, so we have a little bit of time for discussion. I think a lot about how we actually then inform a clinical trial design. I know many of the individuals in this room are thinking hard about how to do this. And I think from a very practical standpoint, how challenging it is. I presented some of this data internally at Hopkins just a week or two ago, and the response from my audience was of cardiac anesthesiologists, oh, we need a clinical trial. And my immediate response to that was, these animal studies are great, they really inform what we do, but doing a clinical trial is really hard because now you've got extracorporeal circulatory support, other devices you have to co-manage. How do you wean? How do you determine hemodynamics? How do you determine titration of support electrolysis? It's incredibly hard. None of that's validated. And so my final little plug, and thank you really to the Abumed community and to the ACURE community, in the intervening time, the preclinical translational studies really inform what we do with patients until we get these definitive clinical trials. And so they're just so vital for us to do and perform and to help guide us while we make sense of what's otherwise confusing clinical data in the background. Again, thank you so much for your time and support.